Good morning, everyone.
Over to you, madam.
Okay, good morning, everyone. So I thank the chairpersons for the introduction. Greetings from Mysore Medical College, my institute. Today's my topic of lecture is sudden cardiac arrest in pregnancy. The previous speaker, Lata madam, has almost done my job. So, cardiac arrest is the cessation of cardiac mechanical activity as confirmed by the absence of circulation, signs of circulation. Sudden cardiac arrest in pregnancy, though rare, is most feared complication and most challenging clinical scenario as it involves two lives, mother and the fetus. The incidence of the maternal cardiac arrest varies significantly between different parts of the world, the incidence being 1 in 12,000 hospital deliveries in USA, 1 in 12,500 in Canada, 1 in 36,000 in UK, and it is as high as 1 in 3,885 in developing country like Taiwan. In India, the exact incidence of the maternal cardiac arrest is not known because of paucity of reliable maternal registry. Coming to causes of cardiac arrest, the causes of the cardiac arrest are better remembered by mnemonic A through H, which was described by American Heart Association. A stands for anesthesia-related causes, which includes ineuroaxial blockade, loss of airway, aspiration, respiratory depression, and hypotension. These anesthesia-related causes are very important because these are preventable causes of cardiac arrest during the pregnancy. B stands for bleeding, which includes the coagulopathy, most commonly uterine atony, uterine rupture, trauma, transfusion reaction, and also placental pathology like placenta accreta, abruptioplacenta, and placenta previa. C stands for cardiovascular causes. It's also one of the most important causes in especially developed country and also in developing country, cardiomyopathy, peripartum cardiomyopathy, myocardial infarction, aortic dissection, arrhythmias, and also exacerbation of previously existing congenital heart rheumatic heart disease. D stands for drugs. Drug-related causes includes anaphylaxis, drug overdose, drug error, magnesium toxicity, insulin overdose, and oxytocin overdose. So, coming to embolic causes of cardiac arrest, so the amniotic fluid embolism being the most feared and deadly cause of cardiac arrest in pregnancy. Pulmonary embolism plays an important role among the embolic causes. F stands for fever, that is the infection and sepsis, which is also important cause, especially in developing country. The general causes for cardiac arrest includes 5H and 5Ts, and finally, the hypertension-related causes includes preeclampsia, eclampsia, HELLP syndrome, and intracranial hemorrhage with increased intracranial pressure. So why we should know the causes is the cause to be addressed promptly, because some of the causes of the cardiac arrest in the pregnancy are completely reversible and they should be recognized early and managed promptly. So coming to the ABC of the maternal physiology, so physiological and both anatomical and physiological changes do occur during the pregnancy in order to accommodate the growing fetus. So one should understand the physiology of the pregnancy for the better resuscitation. Coming to the ABC, airway of the pregnancy. So physiological changes in the upper airway includes hyperemia, hypersecretion, and the edema, which necessitates orotracheal intubation with a smaller size tube, preferably 6 to 7 size tube. There will be increased friability of the mucosa, which leads to bleeding with repeated manipulation. So bleeding is very common problem with the repeated manipulation. So the implication is the intubation during resuscitation should be done by an expert provider or the experienced laryngoscopist. Coming to breathing, oxygen reserve is reduced during the pregnancy. That is due to reduced FRC because of upward push of the diaphragm by the growing fetus, and also because of increased oxygen consumption by the growing fetus. So which tend to predisposes the mother to the rapid development of hypoxia and also increases the risk of early desaturation. Ventilation perfusion mismatch is poorly tolerated by the pregnant patient because of already increased intrapulmonary shunt. Coming to circulation, the major threat during the resuscitation of the pregnant woman is the possibility of aortocaval compression caused by the gravid uterus, especially about 20 weeks, which reduces both preload as well as the stroke volume. So, effective aortocaval decompression is the key to hemodynamic optimization during the cardiac arrest. Coming to management of the cardiac arrest in pregnancy, the priorities being provision of high quality CPR, proper oxygenation, early airway management, relief of aortocaval compression by left uterine manual displacement, and early perimortem cesarean section. These are the priorities. Coming to basic life support, the basic life support comprises simultaneous and coordinated interventions implemented immediately depending on available resources. A minimum of 4 staff members should respond simultaneously. It requires the simultaneous action of minimum 4 members. It's not sequential, it is simultaneous. So documentation of the time of the arrest and early activation of maternal cardiac arrest team, it's also called as maternal code blue or code blue maternal, as soon as unresponsiveness is detected, is the first step. What about the position during the CPR? Historically, tilt has been used as an option to relieve the aortocaval compression during resuscitation, but evidences have shown that chest compression performed in tilted positions are not ideal, as they are less forcible when compared to supine position. So, it is recommended that patients should be preferably placed in supine on a firm hard surface for high quality chest compression, of course with manual left uterine displacement. Coming to chest compression, the chest compression in pregnancy are same as the non-pregnant woman. The hand position is at the center of the chest, that is the lower half of the sternum. The compression rate is at least 100 per minute. The depth is at least 2 inches, perishock pause of less than 10 seconds with complete chest recoil with minimum interruptions. But the key point here is with continuous manual left uterine displacement. Coming to the airway management, it is same as the non-pregnant. So airway should be open with a tilt and chin lift maneuver. 100% oxygen to be delivered at more than 50 liters per minute. Perform the back-end mask ventilation whenever it is available. Deliver each rescue breath over 1 second, 2 breaths over for every 30 chest compressions. One should remember that excessive ventilation should be avoided here. So coming to manual left uterine displacement, it is the key step in the resuscitation of the pregnant woman. Continuous manual left uterine displacement should be performed in all pregnant women who are in cardiac arrest, in which the uterus is palpated at or above the umbilicus to relieve the aortocaval compression during resuscitation. So this MLUD can be performed either by 2-hand technique when the rescuer is on the left side of the patient or the victim, by pushing the uterus by cuffed hands, pulling the uterus with the cuffed 2 hands laterally and upwards, or by 1-hand technique when the rescuer is on the right side of the victim by pushing the uterus laterally and upwards. This is the way one should give the manual left uterine displacement continuously. This is the algorithm showing in-hospital basic life support. It's already been dealt. So coming to advanced airway management, a fast and well-coordinated response to maternal cardiac arrest team by maternal cardiac arrest team, that's also called as maternal code blue team, is very important step. This team should have an adult resuscitation team, obstetric resuscitation team, anesthesia care providers, and also neonatology. So activation of this maternal code blue team always should serve as a universal call to action. One call, many actions. So this maternal code blue team will continue the BLS task, perform the advanced airway management, insert the intravenous access above the diaphragm, administer ACLS drugs, and prepare for the PMCD. Coming to the advanced airway management, so the BLS airway strategies to be continued, and the experienced laryngoscopist or expert rescuer should get into the airway. The airway should be secured by experienced laryngoscopist, optimally by 2 attempts per technique. If the first intubation fails, so go for the second intubation either by the direct laryngoscopy or by the video laryngoscopy. If it also fails, so the supraglottic airway, preferably second generation supraglottic airway, is the rescue therapy. If the 2 attempts of supraglottic airway fail, then one should go back to mask ventilation. So if the mask ventilation is inadequate, so emergency front of neck access, that is the emergency cricothyroidotomy, should be attempted. So one should avoid airway trauma by repeated manipulation. So once the definitive airway is in place, so ventilate with 8 to 10 breaths per minute with continuous capnography monitoring. So it is recommended that continuous capnography should be used whenever it is available. It has many advantages. It confirms the correct placement of the endotracheal tube. It assesses the quality of the chest compression. It also detects the the ROSC, rapid return of spontaneous circulation, an abrupt sustained rise of ETCO2 more than 35 to 40 mmHg always suggest ROSC. Coming to the ACLS drugs, no ACLS drugs and dosages alterations in this. So, owing to alterations in the physiology of the pregnancy, no drug should be withheld. So, IV epinephrine 1 milligram every 3 to 5 minutes is the vasopressor of choice. Amiodarone 300 milligram rapid infusion followed by 150 milligram infusion in case of refractory VA for the VS. So if the cardiac arrest is suspected to be because of magnesium sulfate toxicity, stop magnesium sulfate infusion. 30 ml of 10% calcium gluconate or 10 ml of 10% calcium chlorate to be administered intravenously. If the cardiac arrest in pregnancy is due to last, that is local anesthetic systemic toxicity, high quality chest compression must be complemented with the bolus dose of lipid emulsion 20%, 1.5 ml per kg over 1 minute, followed by 15 ml per kg per hour. So it is the dictum that no ACLS drug should be withheld for the fear of causing teratogenicity or fear of causing any harm to the fetus. Coming to perimortem cesarean delivery, it is defined as the birth of the fetus after maternal cardiac arrest, most commonly during resuscitation. Birth is almost always accomplished through cesarean delivery. The term PMCD was introduced in 1986. It has many benefits. It improves the venous return and the cardiac output of the mother. It decreases the maternal oxygen consumption. It improves the maternal pulmonary mechanics. And of course, it also decreases the risk of hypoxic neurological damage to the baby. So it has both maternal and the fetal benefits. So what is the timing of the PMCD? So it is very crucial factor which determines both maternal and as well as the neonatal survival rate. So it should be performed when ROSC has not occurred within 5 minutes of maternal resuscitation. If the maternal viability is not possible because of fatal injury or prolonged pulselessness, then this PMCD should be started immediately. One should not wait for 4 or 5 minutes. It should be started immediately. So the PMCD should be considered regardless of fetal viability. So where it should be done? The PMCD is also called as resuscitative hysterotomy, should be performed at the site of arrest. So instead of shifting the cardiac arrest patient to the OR. So because it may compromise the high quality chest compression. So evidences have shown that on-site RH, that is resuscitative hysterotomy, found to improve the maternal survival rate compared to operation theatre, that is 72% versus 36%. So it should be very, very abbreviated procedure. So the abbreviated antiseptic pour should be performed. The team should not wait for the full surgical equipment to begin the procedure. An obstetrician with a scalpel is enough. That is, I mean to say that very minimum requirement of the surgical equipments. So one thing we should remember is continuous manual left uterine displacement and high quality CPR should be performed, should be continued throughout the PMCD. That is the most important thing. So this is in-hospital ACLS algorithm, whatever I have discussed so far. So coming to post-cardiac arrest care. So the targeted temperature management is recommended for the pregnant woman who remain comatose even after the resuscitation of from the cardiac arrest. During TTM, the fetus to be continuously monitored for bradycardia. Early organ support strategies should be started according to the cause of the cardiac arrest. So if the patient is in the post-delivery, if there is a failure to achieve ROSC, then this ECMO may be instituted. So if this technique and this expert is available. So ECMO CPR is also called as eCPR, is used as a rescue therapy, especially in maternal cardiac arrest attributed to cardiopulmonary causes. So however, ECMO can worsen the coagulopathy thrombosis. It should be used in patients with massive hemorrhage and DAC. To conclude, although sudden cardiac arrest rarely occurs in pregnant women, the knowledge of causative factors and principles of resuscitation is vital for the emergency team. No necessary procedure or the drugs should be withheld from the mother for the fear of causing harm to the fetus. Stabilization of the mother is the primary focus, and definitely it will offer the best fetal outcome. These are my references. Thank you.
Thank you very much.